Hello, this is Dr. Eric Lindquist with SonoPath.com. This is the first installment of a new series, linguistics and a quick interpretation of sonographic pathology. Just a little insight to our world as telemedicine specialists or clinical sonographers. Just wanted to show you what we see and how we see it. We're going to start with this really interesting case. This is a pug that was essentially moribund and lots of history of GI signs and so forth. And sometimes when you put a probe on things just really jump out and get ugly in a hurry. And this is one of those cases. But when you have a bunch of hypoechoic, undifferentiated pathology, you need to figure out where it's coming from and where the primary problem is. And this is one of those cases. So in a few minutes, we're going to show you exactly how we interpret this case. And so obviously this first still image we have, this is duodenum. This is the end of the C loop, or you get this on S-step 8B, where we get the pancreas, or S-step 14, where we're swinging around off to the C loop after the right kidney and pyloric outflow. So this is the base of the pancreas, or right base of the pancreas. You can see all this hypoechoic irregular tissue. We have a lot of fuzzy fat or reactive mesentery upon it, so we know this is a clinical issue. It's pretty hot from the vascularity there. This is the pancreatoduodenal vein coming in, or pancreatoduodenal vein to the gastroduodenal vein. It goes towards a portal, and so we can see all of this hot pathology here. Okay, so this would be enough to make any animal clinical by itself, but we have lots more to look at. Some older kidney, no big deal. Some pylectasia in this kidneys, but look at this kidney here. We have a little outpocketing or hypoechoic nodular changes, and there's another one over here which we'll see a little bit better. And we have reactive fat around this kidney. We'll see it better in video. Again, always interpret through video and not still images. Still images can really mess with you as far as creating pathology that isn't there. Big splenic infarct here. We know that's bad. You can see this normal tissue to abnormal tissue. You put power Doppler over this and you won't get any flow. And it could have neoplasia underneath it. Always want to put a needle in it. But then we have in the area of the stomach, we have this big, ugly, hypoechoic thing. And you see all this reactive fat, and it's a cross between what you get between an elephant and a rhino. Elephino. And this is what we call elephino lesions. You really got to look at it. It's like, I don't know what that is. So we want to look at the video and see what this thing runs into and comes out of. And that's how we start to interpret it. So here we have another angle of it. Is this big gastric fundus with a bunch of fluid in it? And this is a gastroesophageal inlet? Maybe, maybe not. Let's keep looking. This is why we don't do still images, because stills tell you, yes, there's a problem. That's not supposed to be there, but I don't know what it's attached to. So we're going to jump to video. And it's why we have video in the S-step protocol. So we see this big ugly thing here as it heads over to the pyloric outflow. How many of you are thinking this is gastric stasis, just metabolic ileus, or maybe the pylorus or duodenum are tied up by pancreatitis? Entirely possible. Well, that's when I first looked at it, I was like, that's probably it. But then I looked a little bit further and listened to my own conscience. Listen to that thing in the back, listen to that conscience in the back of your head, because it will really serve you in these tougher cases. And this is why I came up with the curvilinear theory to sonographic pathology, which plug, we are going to have a download of the curvilinear theory and explaining it, how it works and how you interpret everything. It should be live on sonopath.com education, sonopath.com in the next coming weeks. So if you like what you see here, there'll be plenty of that and a full hour dedicated to curvilinear theory. But going back to this case, this was the image. This is a key image. Now, this is S-step 13. It's my absolute favorite maneuver on the S-step abdominal protocol, because it gives us the pylorus and it also gives us the portal hilus. If you're down towards the sternum, you're going to get the you're going to get the pylorus down towards the sternum. You slide up towards the spine, and then you're going to get the portal vein and its branches. You see the portal vein here, sort of, but if you slide towards the spine, you get more portal veins. So you have a shunt hunt and a pyloric outflow assessment for obstructions and cornicobs and fabric and whatever foreign body you're looking for. So it's always there no matter what's in the stomach, even if you have this big dilation of the fundus. But this isn't a dilation of the fundus. Why is that? Because we have the curvilinear theory. Now we see all this enhanced fat. So we know this is all clinical, along with the pancreas, along with the splenic infarct, and the probable necrosis. But if you look closely, here's the duodenum, beginning of the duodenum, and the lumen. Follow the lumen of the intestine, see what happens. The lumen goes up here, lumen goes over here, and it's separate. This is the lumen. This is the lumen that is squeezed down, and you have this big pocket of fluid here. This is a mural abscess within the stomach. And when we put colorfully, you see the separation of the wall from the lumen of the stomach. So this dog has a mural gastric abscess. Why he has that, who knows? Maybe he swallowed a toothpick and it's in there somewhere, but it's key because yes, we can drain this, but this is a surgical case. This dog, unfortunately, was in really bad shape. You can imagine he has a bomb that went off inside him, multiple spots. He's got the pancreatic bomb, he's got the splenic bomb, he's got the gastric bomb here. He's got to deal with all of that. So this is one where I plasma these guys. Definitely plasma. Give them some help from that standpoint, because we wasted a lot of elements that are involved in plasma, that have plasma. So I'd supplement it with plasma, lots of antibiotics, of course, IV fluid support, and I would drain this first. Know what you're dealing with, get it drained as much as possible, take the pathological load off of it, maybe put a needle in the pancreas and a needle in the spleen, make sure there's no obvious neoplasia going on there, and then set them up for surgery to get them in there. See if there's some sort of toothpick or something, maybe this hyperechoic thing that's sitting right here, that just an echo of, or is it something else? Is there a penetrating needle in there or something? I don't know, because we have all this other stuff going on in here. There's only one way to find out, and that's surgery. But this is what the curvilinear theory will do for you. Follow the lines. And next month, or next installment of the linguistics, we're going to look at another case of intestinal patterns that are getting disrupted. And then we'll move on and on and on. So we should be putting these out there every month. I hope you like what you see. These are made to look at in between appointments, maybe when you're golfing down a sandwich at lunchtime. I remember what it was like in clinics, but you still want to learn, you still want to grow, and we're going to help you do that. So welcome to SonoPath, our linguistics series, and also join Peter Modler's cardiac 5 minutes. It's the same sort of thing, but north of the diaphragm with that beating heart that we all want to know what's going on with it. So Peter Modler and linguistics for the abdomen, Peter Modler for the echo. Great to have you here, and hope you enjoy our series.